Okay, chapter 26, the last chapter in this unit in dealing with pain management. This is on non-opioid and opioid analgesics to manage pain. This is just a good picture talking about the different pain receptors and the different place that everything works. The beginning of your chapter goes over the pain threshold. It's very individual. That's why they say pain is individual. Everybody has certain receptors and how they respond. That's their pain tolerance. That's like a genetic thing. And so whatever the person says their pain is, that's what their pain is. It is very individual. We have different pain receptors, which it talks about. We're not going to go really into neuropathic pain management in this chapter. It goes over the pathophysiology and different things on the first few pages. Now, your non-opioid analgesics in the beginning of your chapter starts talking about the NSAIDs, non-steroidal anti-inflammatories, which we talked about in the previous chapter, so I'm not going to go over that again. Types of pain is in table 26.1, which might be a good thing to look over, talking about what kind of things are used, but this kind of talks about it here, but it also, your table helps you. Now we're going to go into acetaminophen, which everyone knows as Tylenol, but Tylenol is a brand. Acetaminophen is the drug. Acetaminophen is a non-opioid. It's an analgesic, which means it goes against pain, helps pain, stops pain. It is very popular. It can be used in infants all the way up to elderly. It's non-opioid, and it is not a non-steroidal. It does have a little effect on the prostaglandins, but nothing significant. There is a prototype chart, 26.1, on the bottom of page 355. Contraindication, severe hepatic or renal disease, and alcoholism. So I have this picture on here. You cannot drink alcohol and take acetaminophen. There are multiple acetaminophen products over the counter, and many things, like you can see from this picture here. Many products contain acetaminophen and people don't realize it. The problem with acetaminophen is it can be fatal. It will quickly damage the liver. It is not the drug to do overdose on. I still remember losing a patient that overdosed on acetaminophen. She was not young, I want to say her 40s, maybe 50s, and it was a suicide attempt taking acetaminophen. Unfortunately, she did succeed, but not rapidly. She quickly went into liver failure. The first 24 hours she was awake on a ventilator. I still remember her watching her liver shut down, watching her slowly die. It took her 4 days to die. Nothing we could do but watch her slowly die. It was absolutely horrible. So overdoses, or people that are on large long-term doses of acetaminophen, have to really watch for the effects. So you have a nursing process in the bottom of page 3, starts at the bottom, it's page 356, and you notice nursing interventions are checking the liver enzymes, keeping it out of reach of children, advising not to self-medicate for longer than 10 days in an adult, 5 days in a child, calling poison control, especially if a child gets into it, and that there is a maximum dose. It's 2,000 milligrams or 2 grams per day is the suggestion, and 4 grams a day to avoid liver damage. For overdose on acetaminophen, this is your drug, acetylcysteine. That is the antidote for acetaminophen or Tylenol overdose. The other name for it is Mucomyst. Acetylcysteine, you need to know. You do have the, I think I mentioned the prototype. Yes, I did. Okay. We're going to move on. There are some things other than non-steroidals and acetaminophen. I stuck the tramadol in here. Start with here. Ketorolac, which is Toradol, is the brand name. Ketorolac is used quite often. It is actually a non-steroidal. I think it was in your charts in the previous chapter, but I didn't touch on it, which I should have. Ketorolac, or commonly called Toradol, is an excellent non-steroidal for acute pain. It's actually given after procedures. It is given in recovery room. It is a non-narcotic, excellent anti-inflammatory to attack pain, used for just immediate, very, very short-term acute cases. Now, tramadol I put on here because it doesn't quite fit anywhere. Tramadol is listed in table 26.2 on Analgesics, all the way in the bottom under miscellaneous. It is not an opioid, yet it was made to be able to use for acute pain, even chronic pain, instead of giving them opioids. Fortunately, they found it's somehow broken down in the body, and some people can actually get addicted to it, and it's now being abused, and it was not on the controlled substance list, but it is now, it's not a Schedule 2. I want to say it's a Schedule 3, where the opioids are Schedule 2s, but it is on there now and is considered a controlled substance. It is used for moderate to severe pain, contraindicated in severe alcoholism, and not to be used with opioids. It can cause nausea, vomiting, dizziness, constipation, headache. It is a category C for pregnancy. Okay, I found this picture I thought was really good, because now we're going to get in the opioid analgesics, which start briefly on the bottom of page 356 and then go flip on over to page 358. It explains to you how they are used. Yes, they are often called narcotics. Act as an agonist to produce the effect of analgesia in your body. Give relief to moderate to severe pain. Used when pain is too severe to be controlled with NSAIDs. All narcotic analgesics are prescription because they're controlled substances. Please note your herbal alert 26.2 on page 358. Opioid taken with kava kava, valerian, and St. John's wort may increase sedation. Where non-opioid analgesics work on the peripheral nervous system, the opioids work on the central nervous system. So anything that's going to work on the central nervous system can have those effects, which I'm going to go into here. First, I'll show you this slide. Talks about the opioids. Your text actually breaks it down also. I just found this was good on your opioids, your classification, how they work, and then your naturally occurring synthetic opioid that your text does talk about, and your antagonist, which I will cover more in a minute. So your opioids, central nervous system depression. So once you depress the central nervous system, you can suppress the respiratory drive. So they have respiratory depression, which is the big, very, very, very important to anybody receiving an analgesic, an opioid analgesic, to monitor the respiratory rate. It can suppress their urge to cough, so they will have trouble clearing their airway. And the only exception, meperidine, often called Demerol, meperidine is the only one that does not have an antitussive or suppressing a cough. So a lot of times I have prescribed codeine, because codeine is a wonderful antitussive, a cough suppressant. I'm going to flip over here to page 361, table 26.3, goes over the opioids, the opium, and the synthetics. The first one listed is your codeine. Your list really goes codeine, then hydrocodone, hydromorphone, meperidine, down to morphine, oxycodone, down to your fentanyl, and that is the order of, strength of these. So as your text lists them, it goes from the weakest to the most potent. That's the word I couldn't think of, potent. So your codeine can be sub-Q, IM, can be given by mouth. Most of these are everything, and if you'll notice, they are category C and often category D in pregnancy for all of them. Your codeine can be given, and hydrocodone, hydromorphone can all be given in conjunction with acetaminophen. It's sometimes even with aspirin. When you get down to, let me see, it should have it listed here, your hydrocodone can sometimes combined with acetaminophen or with ibuprofen. That's why you'll see Vicaprofen, brand names of Vicaprofen versus Lortab, where Lortab and Vicodin have acetaminophen in them. There's Lortab ASA, which is Lortab with hydrocodone with aspirin. And then there's Vicaprofen, which is hydrocodone with ibuprofen. And chlorpheniramine, which is Tussinex. It's often called Tussinex. It has cough medicine with hydrocodone in it. It's why am I telling you this? You need to know these as a nurse. You need to distinguish between them, because if it's people with medicines where you have to look at ibuprofen being protein bound or acetaminophen and watching that they're not taking other products with acetaminophen to get acetaminophen toxicity. Does it have aspirin, and you're worrying about prostaglandins and any other aspirin derivative they're taking. So be able to look on that chart and distinguish between those. Very important for a nurse to know those. Your next in potency is your hydromorphone, many people refer to as Dilaudid. It is for moderate to severe pain. It is a category C for pregnancy. It's given orally IV, and it can actually be given rectally. Next, I'm going to go right down to meperidine, which is often called Demerol. Used to be used all the time, not used as often now. It is just for very, very short periods of acute pain. It's given PO, subcutaneous, IM, or IV, multiple routes that it can be given. Often used in GI surgeries for pain post-op. Your morphine sulfate, which has a very strong respiratory depression. What else? Let's see. Your oxycodone comes next. It's just given in a pill form, moderate to severe pain. Category D in third trimester of pregnancy. Should not take for extended period of time, but people do. Very, very psychologically, physically addicting. So all the opioids are. Oxycodone is another one. That's Percocet when it's given with acetaminophen. Percodan when it's given with aspirin. I always remember the difference between the two. If I was given that brand name, Percocet or Percodan, the Percocet has T in it, so it has Tylenol. The Percodan has A in it, so it has aspirin. Although on NCLEX, I think you're just going to get the generics. It might say oxycodone with acetaminophen or oxycodone with aspirin, but as a practicing nurse, you should be able to distinguish the two. And I don't know, I haven't decided yet. I may throw it that way on an exam for you, because you need to understand, again, for that teaching with the patient. Skip down to your fentanyl. Fentanyl is very, very, very potent. Your text tells you that hydromorphone, which we know is Dilaudid, is 6 times more potent. I'm trying to find it on here. I don't see dilaudid hydromorphine on here, but anyway, your text tells you it's 6 times more potent than morphine. Where fentanyl, it's hard to find, but I've seen things saying it's as much as 50 times more potent than morphine. It kicks into the body, the system, much faster, even the morphine within a couple minutes, and fentanyl also. Fentanyl is one of those things, unfortunately, that is out on the streets. It's more addictive, I've heard, than heroin. And it comes in a patch transdermal form. Fentanyl is the only one that comes in a transdermal form. And people have overdosed by literally chewing on the fentanyl patch and have died. It is that potent. So let's see. You have, I said, look over that table, the fentanyl all the way in the bottom, your methadone, which is an opioid, but it's used for opioid addiction. Interesting. So they just addict them to something else that doesn't have the severe effects on the body, which I think is terrible. And it's used in drug abuse programs to get them off the other narcotics and without having that respiratory depression and problems like that. So your text, please read through it. You have your morphine chart. You have your interactions to look over in your nursing process. Again, not using with alcohol because alcohol is a CNS depressant and all opioids are CNS depressants. So that should be a given in your brain at this point. Then you go into the hydromorphine, hydromorphone. Contraindications, please note on here, all opioid analgesics are contraindicated in a head injury, again, because that central nervous system issue and depression and buildup of CO2 and respiratory depression. There's a thing on the bottom, a safety thing on the bottom, page 360, on not confusing drugs. I talked about combinations. Okay, I'm going to move on to here, page 362, talking about PCA pumps. You may have been exposed to PCA pumps at this point. PCA stands for patient-controlled analgesic. So it is a syringe that gets put in here with meperidine, or usually you'll see meperidine or morphine, most often morphine in there. It is locked with a key to keep anybody from getting in it. The patient has a button. It is prescribed in a set amount, and you program the little computer machine. So they can have just what they give themselves, a dose set for the patient to push the button when they're hurting. When you program it, you program exactly as it's ordered, as you need it, that when they push the button, it'll give them a set dose that you have programmed in. It'll always beep to them that they pushed it, but you also set the time limit between doses. So if they push it, it gives them a dose. If they push it again too soon for the next dose, it'll beep at them, but it will not give them another dose, so they cannot overdose themselves. Also, although they may have this where every 5 minutes or so it will allow a dose if they push the button, they have just so much they could get in 1 hour. So if they meet that max before that hour time is up and they still need pain medicine, it's not going to give the tube. The other setting is they have the PCA, the dose that they can give themselves, and they have a basal. So you set it so it's giving so much every hour, plus they can add their doses as prescribed as you set the machine. Does that mean that's all the patient can get? If this is not managing their pain, you're calling the doctor to get it adjusted. Major thing is to have the antidote, but I'm going to cover the antidote in a couple of slides because I want to cover children first. So the biggest thing with these, with the PCA pump, you should have a flow sheet where you monitoring the respiratory rate, their heart rate, their blood pressure, because you can have hypotension also along with the respiratory depression because the central nervous system depression. So with kids, your text has a little section on opioid use, special population children on page 362. There's certain scales you use. I'm not going into that here because you'll get that in pediatrics. This is just a really good chart talking about the things, and this is where you'll see ketorolac, which good old Toradol is often used. It can be used IV, orally. It's even given IM, but not usually in kids. It really hurts IM. So, overdose on opioids. Your antagonist is Narcan or naloxone. You need to know the naloxone. I gave this picture to help stick in your head. This is to reverse opioid overdose, or if their respiratory rate is dropping because of the narcotic, you give them an injection. Let me see. I think that's about all here. Nubane. I didn't include Nubane in here. So on page 364, chart 26.3, nalbuphine. I'm sorry, I know it as Nubane. Nalbuphine is an opioid agonist antagonist. So it is given. Again, I apologize, I completely forgot to put a slide in on these. What it is they put a little of this naloxone or Narcan in with the opioid to make a drug to try to prevent the opioid dependence for people with pain. So some of the ones that you want to know are the pentozocaine, which is Talwin, and commonly nalbuphine or Nubane, and butorphanol tartrate, which you will hear the name Stadol. And these are opioid agonist, antagonist, analgesics. Not supposed to be able to build a dependence on them, but again, unfortunately, just like Tramadol, people do sometimes get addicted to these. It's not used for things with really, really severe pain, such as cancer. Because there is an opioid in there, there is some central nervous system depression, but not significant because it has the naloxone built into it. If you look on the table 26.4 on the bottom page 364 to become familiar with which ones are in this category. And now we're going to move into the headaches, migraines and cluster headaches. Not that you need to identify cluster and migraine headaches, but I gave you this picture to show the difference of presentation for tension, migraine, and cluster headaches. So there's different management for them. They often will overlap, that the drugs for one are used on the other. So with cluster headaches, abortive is to stop the cluster, and these are drugs that are listed for your migraine headaches. Your migraine headache table is 26.2. So you'll see the same drugs used to abort a cluster headache that you're going to also see, except for the prednisone here, that's added to them, that you'll see used in here for your migraine. Now your migraine headache is prophylaxis. This is someone that has chronic migraines and so recurrent that you try to keep them on. Often I've used the beta blockers. Your beta blockers, remember, they block those beta receptors on the sympathetic nervous system, the beta 1, beta 2, and those end in the OLOL. You have calcium channel blockers, which we haven't really covered yet. We'll get them more in the cardiac drugs, but the calcium channel blockers, let's see, diltiazem is one. Tricyclic antidepressants, which you haven't covered either, and certain anticonvulsants. All these can be used for trying to prevent the onset or decrease the frequency of migraines. And then once a migraine hits in the acute episode, they're sometimes given just these non-specifics, but a lot of people with true migraines have these other forms of management. Table 26.6 on the top of page 367, sumatriptan. The most common ones I've seen, zomatriptan. If you see, they all end in the triptan. And what's easy and nice to know is these are the triptans. So all the triptans for migraines end in that word triptan. So it's easy to see a triptan at the end of that generic name, and you know it is a migraine medication for acute migraines. Not prophylaxis, not preventive, but for that acute migraine. They're all pregnancy category C. Sumatriptan, there's a chart 26.4 on the bottom. Make sure to look over this, your contraindications, especially caution in renal dysfunction and seizures. And there's a lot of drug lab food interactions, especially MAO inhibitors, SSRIs, selective serotonin. We'll get into those with it. Well, just no SSRIs, because we'll get into that when we get into the antidepressants. These medications to abort the migraine come in multiple forms. They can be nasal, subcutaneously, in a pill form, and often these medicines are used in conjunction with these as the prophylaxis and then the acute episodes over here. I have had people that come in really with an acute migraine, give them one of the doses of their Imitrex or whatever they're on, sumatriptan, along with a non-steroidal. I might even give them an injection of ketorolac that I can give IM, and some Phenergan, promethazine, which is an antiemetic, and have them take one of their triptans and lay down in the dark. Okay, so enough covered there, and that is actually the end of this whole unit on the pain management and anti-inflammatories. I just thought this was cute. Laughter is the best medicine. Take your prescription to a funny-looking pharmacist. And that's the end of Unit 7. And no more pain with this unit.